Hi, Raphael here, and here is Ask Me Anything for August the 15th. I've got half a dozen questions today, and to start with, Rose says, "Hi Raph, just got a question regarding your latest Ask Me Anything video." Now I'm getting Ask Me Anythings about my Ask Me Anythings. When you're working with when you're working with tolerable pain, how to describe to the clients that it's safe? Pain equals damage in a lot of minds. Would you just go down the pain science road? Or if you're dealing with arthritis, would you say using the painful area helps the inflammation go down? Also, giving people homework. So let's say it's an irritated shoulder. You give them the exercise that irritates the shoulder the most, but is it a daily 3 sets of 10 reps or 2 to 3 days a week? Or is it best to work it daily when dealing with pain so it's not considered as such strength building? In regards to the pain equals damage question, you can't fix the degeneration, but you can help with reducing pain, as other people with the same degeneration have no pain. Would that be the way you'd explain it? So basically there are 2 questions there. One is, given that it is perfectly safe for in chronic pain for people to exercise in pain, and specifically it's perfectly safe when people's pain is aggravated by the exercise. And then the second, so the first question is, how do you communicate that to clients who might be fearful of the pain causing them damage? And the second question is, how much exercise should clients do in pain rehab if you're prescribing or giving the painful exercise as their or part of their rehab? All right, so first question, how do you communicate with clients and reassure them when they're exercising and the exercise aggravates their symptoms that's perfectly safe? Well, I think I wouldn't go down the pain science road unless the client was interested in learning the pain science. The client's not coming to us to learn about pain science. They're coming to us because they don't want their back to hurt anymore and they want to be able to play footy or play with their kids or whatever it might be. So I wouldn't explain pain science to them unless they particularly wanted to know about it. Explaining pain science to people hasn't been shown to be more effective than not explaining pain science to people. So in terms of reducing their pain or getting them back to doing their functional activities. So I would be more inclined to use a combination of framing and behavioural experiments. So I would frame it. By framing, I mean before you even exercise, during the initial assessment, during the consult, or when you're talking with them, I would, subtly and also explicitly communicate that we're going to try and reproduce the symptom, and if we do, that's a good thing. And that tells us we're on the right track. So you could just frame it like that. And I believe for most people, you probably won't have a problem with them accepting that, because people accept that routinely when they go to the physio or the osteopath or the chiropractor or the massage therapist, and that person sticks their elbow, the practitioner sticks their elbow in the sorest part of your back and makes it, really hurt. And people accept that is doing them good. So I think it's if you frame your exercises that way, you probably have reasonable success with most clients. The other route you can go down is behavioural experiments. And I would frame that, if it hurts during, that's good, and it'll probably feel better afterwards if it hurts during. So then you can also do behavioural experiments, like if they think something is going to cause damage, and you can frame it effectively, or if you can kind of get them to do it without realising. So a classic one is someone who can't touch their toes. So if they stand up, they ask them to touch their toes, they're like, "Oh, that's as far as I can go because my back really hurts." But if you get them to sit in a seat and say, "Okay, you're sitting in your seat, can you reach down and touch your shoes?" And then when they're touching their shoes, you go, okay, now can you lift your bum out of the seat? And before you know it, before they know it, they're touching their toes. So that would be one example. And there are many other ways that you could kind of, I call it hiding the veggies in with the bolognese sauce. Like young kids don't like eating their veggies, but if they can't see the veggies, they're perfectly happy to eat them. Kind of the same. And then you can kind of, when they're touching their toes and standing up, you scratch your head and go, well, that's cool, isn't it? Because we thought you couldn't touch your toes, but apparently you've got better. So that's awesome. So that's how I would approach that. I don't really think it's fruitful getting into a long and complex or even a short and simple discussion with clients about pain science unless the client is interested, in which case go for gold in explaining the pain science. And in regards to giving to the second part of the question, which is giving people homework. So let's say it's an irritated shoulder. You give them the exercise that irritates the shoulder the most, essentially how many reps and how often do you give that and what's the purpose? Is it a strengthening exercise or is it something else? So giving someone an exercise that replicates their pain has not been shown to be better or worse than any other way of giving people exercise. So it's not necessarily like, the thing I would do with people, but it is definitely a thing I would do and that you can do with people. Chris Littlewood, Professor Chris Littlewood in the UK, who's a shoulder researcher, a rotator cuff researcher, did a study published in 2016 where he gave clients a single self-managed exercise at home with a flex band that was and they compared it against usual physiotherapy, and the usual physiotherapy was just any treatment that the physiotherapist deemed appropriate. So, exercise, stretching, manual therapy, etc. And they compared it with this single home-based exercise with a flex band. And the exercise that people got to do at home was their most painful movement. So Chris Littlewood, the researcher, he specifically targeted the client's most painful movement and got them to do it with added load. So he tried to produce as much pain as was tolerable for the client with the exercise. That was actually what they were going for. And what he did in the research protocol was 3 sets of 10 every day, 7 days a week. And what he said, he trained the clients, and I think this is really important because I think this gets to the self-efficacy component, is that he trained the client to find the most painful position. Is it here? Is it here? Is it here? Where's the painful position? And then basically the client to self-monitor, where's the most painful angle, and then adjust the resistance so the pain was as much as they could tolerate. And then he trained them, if the pain was too much, you just reduce the resistance, use the band a bit slacker. And after a while, what you find is the pain will decrease. After the second set, or the second day or the third day or whatever, you'll find that there's less pain with the same movement, the same angle, the same degree of resistance. And so what you do then is you hold the band a bit lower down, you get more resistance and you increase the load so that the pain is as much as you can tolerate again. And so he taught them how to progress that exercise themselves, and he gave them a criteria to progress it and also to regress it to make it easier. And so that's why it was self-managed. It wasn't just like go home and do 3 sets of 10 of these every day and come back in 6 weeks. It was like progress this exercise at home. I think if you do that, what Chris Littlewood did in the study, I think is very important to do. If you do that, I would give the client 3 sets of 10 and I would get them to do 3 sets of 10 in your presence with, a minute or 2 minutes break in between the exercises, the sets, at the maximum tolerable pain. And then I would wait afterwards, don't do that right at the end of the session. Do it kind of with at least 5 or 10 minutes left in the session to see if the pain settles afterwards. If they get to the end of the third set and it's really painful, but then a couple of minutes later, they're like, oh yeah, actually my shoulder's feeling better now. Well, that's a really, that Chris used that as a good, he said that's a good prognostic indicator that they will tolerate, that, they can tolerate that. And that shows the client, that's a behavioral experiment, right? So they're doing it, it's painful. And then after they finish, it's like, oh, it feels better, right? So, but it's important to do the full 3 sets with them in your presence. One, to make sure that they understand how to adjust it for themselves and how to progress it or regress it, and 2, to see that they can tolerate that. And then if they can tolerate that, do it 7 days a week. So it doesn't need to be a strengthening exercise, and the amount of resistance they'll use will be highly variable depending on their pain. So you might have someone that could overhead press 50 kilos, but they only need a light, thin flex band with their shoulder in a certain position to really aggravate the pain symptoms. So the level of resistance they're using might be well below the threshold required to produce a strengthening response, but might be still super painful. So think of this exercise not as a strengthening exercise. It's loading the painful movement. It's just exacerbating the symptom. And basically we're playing with the pain system and desensitizing the pain system by repeated exposure rather than strengthening per se. So repeated exposure, desensitizing daily is better than 2 times a week. So that's what I would go with. That's what the study used. So I hope that helps, Rose. Okay. Keely asks, morning, Raf. On the other side of the cert course, I'm going to be working with young dancers as well as, quote, normal people. I'm just wondering your thoughts on having younger people aged 14 or so on the reformer. If there are things I shouldn't do or have lighter or heavier springs, etc. I know when I've been to Pilates studios, they don't allow people under the age of 18. Is that just for group classes? So, Keely, the reason Pilates studios don't have, or most Pilates studios don't allow people under the age of 18 is simply a legal one. In Australia, in order to supervise a minor, somebody who's not legally an adult, someone who's under the age of 18, with the parents absent, so if the parents of that minor, that child, are not in the room, the person supervising them has to have what's called a working with children check, which is a police check that that checks that you're a suitable person to be supervising children. You've got no criminal history and whatever. So just because in Australia in particular there are some complex legalities around supervising minors, that is why the majority of Pilates studios don't allow children under 18 to participate in their classes. We're the same. Most of our trainers don't have current working with children checks, so we don't allow people under the age of 18 to enrol in our Pilates course unless they are supervised by their parent or legal guardian 100% of the time. So by supervised, I mean the parent or legal guardian must be physically present in the same room as the child at all times, no toilet breaks, nothing, just with them all the time, whenever they are doing their coursework, whenever they are, supervised by one of our trainers. So our trainer is never alone with that student, or even if there's a group of 12 students, the student is never under the complete supervision of the trainer. Their parent or guardian is always present. So that's really just kind of a child protection law in Australia that we have, and that's why that is the case. As to do you need to modify things? And if you want to get a working with children check yourself, it's very easy, and it's like $60 or something like that. You just have to fill out a couple of forms at the police station, and then they'll take a few days to check your criminal history, and then you get a certificate in the mail. So it's pretty easy to do on an individual basis. And as to when you're supervising children in Reformer, or you're teaching children, 14-year-olds, adolescents in Reformer, no, you can treat them exactly like adults, as in work them to their level of fitness, their level of strength, their level of coordination, their level of flexibility. And, if you're working with younger children, we'll talk about their level of task maturity. So, like younger children might struggle to understand instructions sometimes, but for 14-year-olds, they should be totally fine to understand the same instructions you'd give adults. And it's absolutely perfectly safe to give them any exercise you would give an adult. So including heavy resistance exercises, including strong stretches, including, any kind of exercise you could do on a Reformer is perfectly, completely, utterly, totally, and in all other ways safe and appropriate for 14-year-olds. So, yeah, go for gold. But make sure you get a working with children check. Okay, Hillary asks, hey, Raphael, looking to purchase a baby arc barrel. Depending on where you buy it, they're different sizes. Is there a standard size, more specifically the height of it? Okay, well, I don't know about standard, but I've got one of these ones at home. It's Merrithew / Stott Pilates arc barrel. And my one is, I measured it, the height of it is 17 centimetres, 170 millimetres at the highest point. And we've got a few other ones at our Northcote campus by a different company called Pilates Health Equipment. And I haven't measured them, but I've used them, and I've used the one I've got here at home. I reckon they're pretty close to the same height. Actually, the Pilates Health Equipment's are great because they come actually with 3 different adjustable height ones. So, but their smallest height, I think, is pretty much the same as the Stott Pilates one. So yeah, I'm sorry I can't give you any more detailed information than that, but I hope that helps. All right, Anne says, hey, Raph, I know we just spoke about ACL injury and healing, but I wanted to ask you, I think this was in the anatomy course that we talked about this. We talked about anatomy of the knee. So in terms of a complete rupture of an ACL, from my understanding, that ACL is done and your knee is unstable unless you have a reconstruction. So when we speak of healing of the ACL, are we just talking about inflammation and swelling going down and the ligament is calcified over? All right, so there's another part to the question, but I'm just going to clarify first. So ACL stands for anterior cruciate ligament, and it's one of 2 ligaments deep inside the knee. And the main function of the anterior cruciate ligament, or the ACL, is to prevent the tibia, the shin bone, from sliding forwards, your knee from basically dislocating and the tibia from sliding forwards. That's the main function of the ACL. And the ACL is commonly injured in sports that require pivoting. So particularly things like ball sports, soccer, football, rugby, things like that, netball, where people pivot and change direction. And women are more prone to injure ACLs than men. So that's a little bit of background. And then now to repeat the question, in terms of a complete rupture of an ACL, so complete rupture means the ligament is completely ruptured, completely separated. From my understanding, that ACL is done and your knee is unstable unless you have a reconstruction. So when we speak of healing of the ACL, are we just talking about inflammation and swelling going down and the ligament is calcified over? And also, there have been studies recently of complete rehab back to sport for complete ACL ruptures without having any surgery through strengthening the surrounding muscles. I assume that kind of rehab would commence after the initial swelling or inflammation went down and after the patient had relearnt how to use the leg again post-injury. Sorry, lengthy question, because definitely an area I'm interested in, given I play a lot of women's team sports and women are more predisposed to getting ACL ruptures. That is correct, and women are more predisposed to it. And the reasons women are predisposed to it are not well understood. There are multiple potential reasons, including hormonal, including angle of the hips and legs, including the internal shape of the bones of the knee joint, including ACL susceptibility to hormones at different stages of the menstrual cycle. Yes, and then there's some genetic influences potentially, and also a whole bunch of grey area where we're not quite sure why women are more predisposed, but definitely women are. So, all right. So first things first. I think actually your question has two parts. One is when you rupture your ACL completely, and then will it heal? Will it heal over? And the answer to that is probably not. So if you completely tear the ligament, and as in the ligament is completely separated, no part, the ligament is not in, two parts of the ligament are not in contact with each other. Excuse me. My understanding is it's not likely to heal, although I did find a couple of case reports. Excuse me, they were just, so case reports are a report of a single case of people's, of ACLs, completely ruptured ACLs spontaneously healing without surgery. So it is possible, but my understanding is it's probably not very likely. And so once you completely rupture it, your options are essentially either have it surgically reconstructed and then do physical rehab, or don't have it surgically reconstructed and do the physical rehab and live without an ACL, basically. And so if you there have been quite a few good quality studies with long-term follow-up of those two groups of people having surgery to repair their completely torn ACL, and then another group of people not having surgery, and following those people for years and finding out multiple outcomes like the rate of knee arthritis, years down the track, the rate of return to sport, the rate of functional activities, strength in the leg, and the rate of people who choose to not have surgery, the percentage of them who subsequently become dissatisfied with that conservative management and then choose to have surgery later. And found a couple of studies which I'd like to share with you. Let's have a look over here. All right. So first one is, now there are a bunch of studies, but I think this one is a pretty good overview. So I won't bore you with looking through a dozen, which I have in my end note, but I think this one's pretty good. It's from 2019. It's overall study of evidence-based management of anterior cruciate ligament rupture. So it looks at surgery, it looks at exercise, it looks at all possible modalities. And what they found was, do the outcomes of ACL rupture differ depending on management strategy? There are a number of literature reviews comparing outcomes between individuals that are ACL deficient or have had an ACLR, or anterior cruciate ligament reconstruction. So that's the surgery. And the ones who are ACL deficient, that means the ones who don't have an ACL anymore because it was ruptured and it wasn't surgically repaired. So this is basically comparing the outcomes between individuals who don't have surgery and individuals who do have surgery. It's important to note that most studies included in these reviews do not reflect best practice for non-operative management of ACL rupture. For example, many of the non-operatively managed patients in these studies received a diagnostic knee arthroscopy. Some were advised to reduce activity levels, and rehabilitation was often not monitored, or of a low intensity or short duration, or included post-injury immobilization with a brace or cast. So all of those are not evidence-based recommendations. Despite this, these literature reviews support similar outcomes in ACL deficient and ACL reconstructed groups, including similar patient-reported outcomes, knee function, activity levels, quality of life, and either no difference in radiographic osteoarthritis prevalence or a slightly increased prevalence following surgery. So what they say there is that for all measures, including the patient satisfaction, including pain, including function, including activity levels, quality of life, there is no difference between getting it surgically reconstructed and getting it not surgically reconstructed. Now, in terms of arthritis prevalence, it was slightly worse if you had the surgery. This last paragraph is notably, there was also no difference in outcomes between patients who had early ACL reconstruction, patients managed with rehabilitation alone, and those initially managed with rehabilitation who underwent a delayed ACL reconstruction. So whether you had surgery straight away or whether you tried exercise and then later had surgery or whether you tried exercise and didn't have surgery, long-term outcomes were the same. The treatment groups, that's those who had surgery and those who didn't, had similar 5-year functional and radiographic outcomes, but the ACL reconstruction group had more joint effusion, which is weeping or swelling, better self-reported knee function, and lower self-reported fear. Furthermore, Kovalak et al. 2018 found no group difference in time to return to regular physical activity, 8-year knee function, strength, or quality of life between athletes who were managed with neuromuscular training alone, so that's people who had strength and coordination training, or those managed with ACL reconstruction, so surgery. Van Ipperen et al. 2018 compared 20-year outcomes in 50 high-level athletes with an ACL rupture managed with structured rehabilitation and lifestyle modifications or ACL reconstruction. Despite the fact that the ACLR group had less knee laxity, there was no between-group differences in meniscectomy rates, so that's people who had subsequent meniscus surgery, radiographic osteoarthritis, and functional outcomes. Combined, these recent studies support a larger body of evidence demonstrating that, on average, individuals experience similar functional, radiographic, and patient-reported outcomes after ACL rupture, irrespective of management with rehabilitation alone or with ACL reconstruction. So that is pretty much, and you had it 100% spot on correct, that the outcomes, the current research tells us that's a review from 2019, so it's pretty recent. The current research doesn't really support better outcomes for people who have ACL surgery versus people who don't have it repaired. And so what happens is, the way to interpret that, I think, think about it from an anatomical perspective, is those who don't have surgery don't have an ACL anymore, like they're ACL deficient. There is no ACL, but they just strengthen up all of the other structures of the knees. There are other passive structures that also support the ACL, perform the same function as the ACL. The lower distal fibres of the iliotibial band, the band of fascia that goes down past the knee, from the hip to the knee, run parallel with the ACL, and they perform a pretty similar function. Let's have a look at that. So if we look here at the hip, there's the greater trochanter. All right, so if we can imagine that that's the side view of the pelvis, and if we draw in the iliotibial band, it goes from the ilium here and all the way down to now there are several attachments of it, but I'm just going to draw in the one that's of interest to us. It goes down to there. Now I'm going to draw in the ACL. The ACL runs like that. So you can see that this part of the IT band, this lower part here, the fibres run parallel with the fibres of the ACL. And so if you think about the function of the ACL, function of the IT band, or this part of the IT band, they are ideally situated to prevent the tibia sliding forwards like that. So both of those sets of fibres are going to oppose or become tight with that movement. So even for people with no ACL, those fibres of the IT band still provide some significant amount of strength. I can't remember the exact number, but I think in people with intact ACLs, the IT band provides something like 40% of the resistance to anterior shear of the tibia. So it's quite a significant component, and I would imagine, I haven't seen research on it, but my guess would be that when you don't have an ACL, that those fibres of the IT band are subjected to greater force because the ACL is not absorbing any of the force. So the IT band subjected to greater force. So the IT band is a living tissue. It would respond by becoming thicker and stronger. So it would, somewhat absorb the function of the ACL. Then you've also got the joint capsule. You've got your popliteal ligaments at the back. And then you've got the quadriceps. The quadriceps provide a posterior shear force on the knee, which is the same force that the ACL provides. So strengthening the quadriceps and the hamstrings and the gastrocnemius, the calf muscle, can essentially compensate, basically. There's that. Those are my thoughts on ACL reconstruction versus non. And when would you start that rehab? Well, rehab starts basically when you wake up in hospital. And now this is if you had an ACL reconstruction, you would start rehab immediately. If you didn't have one, you would wait, a couple of days, till the swelling went down a little bit. But basically the rehab would consist of weight bearing on it ASAP, with crutches if need be, and just basically loading it as much as it could tolerate, which would not be very much at the beginning. But basically you mobilize it and load it early. So like definitely within 7 days, you would be loading it, you would be trying to straighten it, you would be trying to bend it, and you would just work up from there in a gradual progression. Over at least 9 months. So this is a fairly long-term rehab project, and it would just involve strengthening of the quad, strengthening of the hamstrings, strengthening of the calves, strengthening of the glutes and hip flexors. So basically, like you say, strengthening of the whole leg, plus what they call neuromotor training, or in other words, balance and proprioception. The injury position for the ACL is like so. So kind of a planted foot, knee turning in, leaning over towards the side of the injured leg, and there's a direction change. So it would look like in sport, running and changing direction like that. And so there would be neuromotor training to train the person to, when they change direction, to keep the knee out. So it's called cutting or pivoting in sport. So when you go to pivot, you would keep the knee out when you pivot rather than letting it come in. There'd be a little bit more to it than that, but that's the basic gist. You'd do, squats and jumps and work up to hops and twists and all of that kind of stuff. But that would be over a period of several months. And the process would be identical regardless of whether you had an intact ACL that had been reconstructed or whether you had no ACL. You would just start with your current capacity, very soon after the injury, very soon after surgery, and then you'll just progress gradually as strength and range of motion and control increased. Finally, I think there's a second part to your question, which is, which I'm kind of reading between the lines, which is how do you prevent ACL ruptures if you're a woman playing pivoting sports? Well, what you do is you do an ACL prevention program. And this is what one looks like. A majority of anterior cruciate ligament injuries can be prevented by injury prevention programs. This is from 2019. Also, a systematic review of randomized controlled trials and cluster randomized controlled trials with meta-analysis. So this is pretty high-level stuff. Of 2,219 studies screened, 8 studies were included in the quantitative synthesis, and their analysis revealed a significant reduction in ACL-IR. What's IR? Something rupture? Incidence rate. 8 studies were included in the quantitative synthesis, and their analysis revealed a significant reduction in the ACL incidence rate when athletes received injury prevention programs. Incidence rate ratio 0.47. So that means those who received injury prevention programs had only 0.47 out of chance of getting injured. So in other words, their chance was reduced to 47% of the chance they would have had if they didn't do the injury prevention program. So in other words, they reduced them by 53%. The majority of included injury prevention programs tended to meet minimum best practice recommendations and incorporated plyometric, strengthening, and agility exercises along with feedback on proper landing technique. That's what I just showed you. However, the specific exercises including in each injury prevention program and key factors related to injury prevention program delivery were highly variable. Despite limiting the analysis to only high-quality studies and controlling for time at risk and potential clustering effects, the studies showed that ACL injury prevention programs had a significant protective effect and reduced injury rates by 53%. That is massive. However, significant variability in the specific exercises and the manner of the program delivery suggests that ACL injury prevention programs may be able to be designed with an overarching best practice framework. In other words, just do some strengthening and some range of motion and some control work. So basically what you would do to rehabilitate an ACL injury is what you would do to prevent it. It's the same thing. You're strengthening all the surrounding structures, retraining movement patterns to keep the knee out when you cut, and you're practicing plyometrics and all of that kind of stuff. So there you go. Hope that helps. All right, last one. And this is from second last one. This is from a student who wishes to remain anonymous. It says, "Good morning. I hope you're well. This is a Cert 4 student. I'd like to give some feedback on my studies, please. You may cover this later or not. There's a very distinct difference in moving an aging body. I'm 53, menopausal, and I struggle daily with exercise. I've been super fit in the past and not experienced these issues, so it may be personal and particular only to me. Energy levels are quite low. Movement is hard, and I walk 3 Pilates sessions a week plus restorative or yin yoga 2 or 3 times a week. I do have osteoarthritis in the thoracic spine, but what I'm talking about is general and not specific to that area. I'm great at modifying, and Pilates is the best thing for the spine. Progression is super slow though. Last year I did a lot of weights and still struggled, but did progress a bit with a trainer. It's definitely started from around the age of 51. I guess what I'm trying to say is that it's worth noting the changes in the aging body and frustrations a person may experience who has in the past been able to pick up anything and progress through it easily. As always, I'm thankful and appreciative of the work you and all your team members do. Such a lovely, happy and inspiring group of people." Thank you very much, student who wishes to remain anonymous. Well, I did a bit of digging and found a couple of studies on strength training in post-menopausal women. And I was curious about the rate of, how basically the training sensitivity is how I would phrase it, of post-menopausal women. So in other words, do post-menopausal women in general respond to strength training similarly or differently to folk who aren't post-menopausal women, to premenopausal women or young men or old men or whatever. And so, here's what I found. Changes in muscle mass and strength after menopause. So what they say here is menopause is associated with a natural decline in estrogen that increases visceral fat mass, decreases bone mass density, muscle mass, and strength. This review will examine the role of menopause transition and associated decreases in hormonal status with regards to those changes. We will also overview the efficiency of physical exercise and nutrition on muscle subcharacteristics, by which they mean strength and muscle mass. All right, so I'm not going to read the rest of that for you because if you want, you can look it up yourself. But here's what they found. It is albeit difficult to differentiate between physiological changes that are solely due to age as opposed to those related with menopause. It remains certain, though, that muscle mass and strength decrease in older women, be it due to menopausal status or age. Some methods are available that can attenuate or decrease those muscle mass changes. Exercise, nutrition, hormone replacement, and vitamin D consumption are considered as important contributors to muscle mass, strength, and quality of life. I think that is what, that was part of the conclusion. So basically, without reading you the full body of that paper, but I will I'll put the link to the paper in the description of the video if you want to read it yourself. Women's muscle mass and strength does tend to decline as they age, and it's unclear whether that's how much of that is due to menopause and how much is due to just the aging process and how much is due to lifestyle factors that co-occur with the aging process. And the lifestyle factors that can co-occur are decreased physical activity, decreased protein intake, decreased vitamin D production. And so without getting too technical, basically, this is, I guess how I would interpret that is that potentially post-menopause, as estrogen reduces, women's training sensitivity may decrease. So in other words, if you're very sensitive to training, you do just a little bit of exercise and bam, you get stronger really quickly. Whereas if you're not very sensitive to training, you could do a lot of exercise and only get a little bit stronger. And it sounds to me like, that's what you're describing, that your training sensitivity has decreased. So you still are getting stronger as a result of training, but it's just slower than it was before. So the training sensitivity has decreased. So there are two basic things that you can do to address that. One is, if your training sensitivity has decreased, well, if you just do more training, a bigger dose, you will get, a bigger response. And so if you're less sensitive, you might need a bigger dose than you had previously to get the same response. So in other words, more exercise, more load, etc. The second part is that there are two dietary supplements that may be of benefit, and I'd strongly recommend you go see a qualified dietitian about this. But I can tell you this in general, is that it is crucial to eat enough protein in order to in order to maximize the strength gain from any given workout. As we age, our ability to digest, break down, and make use of protein declines. So if you're older, as we get older, we need more protein to get the same amount of benefit because we're not as good at digesting it or utilizing it than we do when we're younger. So it may be the case, and I've seen a couple of systematic reviews that have found that up to 2 grams per kilo of body weight per day of protein are beneficial. So that would be 2 grams per kilogram per day of protein. So if you were and I'm just making these numbers up, but if I'm not making that number up, that number's from research, but this number I'm making up. If you were a 60 kilogram woman, that would mean 120 grams of protein per day would, in theory, be required to maximize your anabolic response, or in other words, the strength building response. Now that may be even more for some people. So I recommend you go see a dietitian and have them prescribe you, because that's quite a bit of protein. Like, that is quite a bit of protein. And unless you're like having chicken breasts for breakfast, lunch and dinner, or protein supplements, you're very likely not getting that much protein. And the second thing is vitamin D. And I don't know where you live, anonymous student, but if you live anywhere in the southern part of Australia, you're almost certainly vitamin D deficient. And so you, again, should go see a dietitian or a medical doctor and have your vitamin D levels checked. You can do it by blood test. And, you can just buy an over-the-counter at the chemist, 1,000 milligrams per capsule vitamin D supplement. And, if your dietitian or doctor recommends that, that could significantly enhance the strength response that you get from any given workout. So I hope that helps, and thank you very much for sharing. There is one final question. It's from Fonny Hassing, and Fonny says, "Hi, Raf. I'm working through my practice teaching via Zoom." So Fonny's in the Cert 4. "I have a friend in Brisbane who's had to quarantine for 2 weeks after attending her dad's funeral in Melbourne." That sounds tough. "My friend suffers from non-specific low back pain. Someone told her that engaging glutes while exercising could help. I said I didn't know but would consult an expert. Presumably that's me. Thanks. Your tips and thoughts would be much appreciated. By the way, I submitted my final Module 5 written assignment today. Once I have my final 2 gradings and finish my practice teaching hours, I'm all done. Super exciting. Hope you and your loved ones are safe and well." Yes, we are, Fonny. We are all safe and well, although my daughter's going a bit crazy and wants to go get char time at ridiculous hours of the night because she misses going to get char time. But apart from that, we're all safe and well and living our best ISO lives. So the really short answer to glute activation, will it help low back pain, is no. But the slightly longer answer is, if your friend believes that it will help, it possibly will help more than any other form of exercise, because it's been shown that expectation is a very powerful predictor of outcome. So if people expect to have a good outcome, they're much more likely to have a good outcome. And that might not be all placebo, psychological. It might be like when you expect something to work, if she expects the exercises to help, she's more likely to do the exercises. And if she does them, they're more likely to help. So there might be some part of that. So basically, but it seems to me, reading between the lines of what you've said, that she doesn't have a terribly strongly held belief about this. It's just something that she's heard and she's kind of curious about it. And if that's the case, I would just say to her, nah. Any form of exercise, literally any form of exercise, is going to be fantastic, and just generally strengthening all over, including your glutes, but not limited to the glutes, is going to be fantastic. If she's worried that her glutes don't work, you can do a little behavioural experiment with her. Because sometimes people have different capacities to perceive muscles contracting. Like some of us can hear musical cadences and tones more easily than others. Some of us have an ear for languages. Some of us can taste, find the differences and subtle flavors of fine wine more than others. Some of us can see colors more clearly than others, and pick up the fine details of art. And some of us can perceive body sensations more readily than others, and that's just a normal part of human variation. We all have different strengths and weaknesses. And so just whether you can perceive your muscle contracting or not is a terrible indicator of whether it is contracting. It's just not related. You can perceive it or not, doesn't mean it's activating or not. But it's much easier to feel it with your hand is what I'm getting towards. So basically, if you ask her to stand on one leg, put her hand on her butt, okay, just like that, and then lift that other leg behind. Lift the leg up behind her, bring the leg out to the side, and then turn the knee up, okay? And ask her what she feels. Ask her what she feels under her hand. I can pretty much guarantee you what she'll feel is muscles contracting, because it's basically impossible to do that movement unless your glutes contract. So if she can do that movement, I guarantee you her glutes are contracting. In fact, if she can get out of a chair, I guarantee you her glutes are working just fine. If she can walk upstairs, get out of bed in the morning, etc., her glutes are working just fine. And I'm going to link again in the description of the video to a fantastic blog by Greg Lehman, who is a physiotherapist and a chiropractor and a biomechanical researcher, called Have the Butt Muscles of the World Gone Silent, where he talks at length and quite amusingly about the research on this area. But the spoiler alert, TLDR, is no, they haven't. The butt muscles of the world have not gone silent. If you can stand up out of a chair, your butt works just fine. No need to squeeze it. So I hope that helps, Fonnie, and congratulations on completing your course. That is such an awesome achievement. I'm really happy for you. Well, thanks very much for your questions, everyone, and I hope you got some value if you're watching this wherever in the world you are. And if you have a question, I'd love to hear from you, whether you're a student or a subscriber or not. If you're just some person somewhere in the world who has a question about anatomy, biomechanics, injury rehabilitation, I would love to hear from you. You can email me, raphael.b, RAPHAEL, .b for Bob, at breathe, breathe.edu.au. And if I don't know the answer to your question, which is very likely that I won't, I will look it up, because that's what I like doing. So until next time, I hope you're well, hope your loved ones are well and safe, and have a great week. Bye.